Dr. Michael Harrison had exactly 90 seconds before his heart would stop completely, and the only person who could save him was the cardiac ICU nurse he'd humiliated just minutes earlier. As Maria Santos stood over his unconscious body, holding the defibrillator paddles that could restart his heart, she had to decide whether to save the man who'd called her just a nurse. But to understand how a respected cardiologist ended up with his life in the hands of the nurse he'd spent 3 years dismissing, we need to go back to where their professional conflict began. Because sometimes, the people we underestimate are exactly the ones whose expertise we desperately need. And this story, this incredible true story, will show you why experience sometimes trumps education, why humility can be the difference between life and death, and how the most important lesson in medicine isn't found in any textbook. Maria Santos had been working in cardiac intensive care for 23 years when Dr. Michael Harrison arrived at St. Catherine's Medical Center in downtown Boston. At 45, Maria was the most experienced cardiac nurse in the hospital, with an intuitive understanding of heart conditions that had saved countless lives over the decades. She could read an EKG faster than most residents, recognize subtle signs of cardiac distress that escaped newer staff, and predict complications hours before they manifested in measurable ways. Her colleagues called her the Heart Whisperer because of her uncanny ability to know when a patient was about to take a turn for the worse. Maria has saved more lives than half the cardiologists I know. Dr. Patricia Williams, the longtime cardiac department head, often said during staff meetings, "If she tells you something's wrong with a patient's heart, you listen, period." Maria's expertise hadn't come from textbooks alone. She'd earned it through 2 decades of 12-hour shifts, watching over patients whose hearts hung in the balance between life and death. She'd seen every type of cardiac emergency imaginable, learned to recognize patterns that others missed, and developed an almost supernatural ability to predict when a stable patient was about to crash. Her technique for reading patients went far beyond monitoring numbers on screens. Maria would notice changes in skin color that indicated decreased circulation, breathing patterns that suggested developing heart failure, and behavioral changes that warned of neurological complications from cardiac issues. She had what other nurses called the gift, an ability to see what others couldn't. But Dr. Michael Harrison wasn't the type of physician who believed in nursing intuition. Harrison was 38, brilliant, and had arrived at St. Catherine's with impeccable credentials from Johns Hopkins University. He was the kind of cardiologist who could perform complex procedures that other surgeons wouldn't attempt, and he had the ego to match his surgical skills. His reputation preceded him. Youngest department head in Johns Hopkins history, published researcher, and a surgeon whose hands were so steady they said he could perform heart surgery during an earthquake. From his first day at St. Catherine's, Harrison made it clear that he operated according to a strict medical hierarchy. Doctors made decisions based on scientific evidence and medical training. Residents assisted while learning proper protocols, and nurses followed orders while providing basic patient care. Input from nursing staff was neither requested nor appreciated in his medical decision-making process. I didn't spend 12 years in medical education and complete a fellowship at one of the country's top cardiac programs to take advice from someone with a 2-year nursing degree, Harrison said during his first department meeting, a comment that immediately created tension with the nursing staff and set the tone for everything that would follow. Maria's first interaction with Dr. Harrison set the stage for 3 years of professional conflict that would ultimately save his life. Mrs. Eleanor Chen, a 68-year-old retired teacher recovering from a triple bypass surgery, was showing signs that concerned Maria deeply. The patient's heart rhythm was stable according to the electronic monitors. Her blood pressure was within acceptable ranges, and her post-operative lab values looked normal to anyone reading the numbers. But Maria noticed subtle changes in her color, breathing pattern, and responsiveness that suggested developing complications that weren't yet showing up in measurable data. "Dr. Harrison," Maria said respectfully as he made his morning rounds, "I'm concerned about Mrs. Chen in bed 3. Her presentation suggests possible pericardial effusion developing." Harrison barely looked up from his tablet computer, where he was reviewing lab results and cardiac catheterization images. "Her numbers are fine, Nurse Santos. EKG shows normal sinus rhythm. Blood pressure is stable at 125/78, and her drainage output is within normal limits. Perhaps you should focus on patient comfort measures rather than attempting medical diagnosis." "Sir, with respect, I've been monitoring cardiac patients for over 20 years, Maria continued, her voice remaining calm and professional despite the dismissive tone. "Mrs. Chen's breathing pattern has changed subtly over the past 4 hours. Her jugular venous distension is slightly elevated, and her heart sounds are becoming more muffled. These symptoms are consistent with—" "Nurse Santos," Harrison interrupted, his voice carrying the kind of authoritative tone that silenced rooms and ended conversations. "I appreciate your enthusiasm for patient care, but I am the cardiologist here with extensive training in cardiac pathophysiology. Mrs. Chen is stable according to all objective measures, and that's my medical opinion based on scientific evidence, not subjective nursing observations." Maria felt her face flush with frustration, but she persisted because she genuinely believed Mrs. Chen was in danger. "Dr. Harrison, I've seen this exact presentation dozens of times before. If we could just do an echocardiogram to rule out pericardial effusion—" "That's enough," Harrison said sharply, his tone drawing the attention of nearby residents and other nursing staff. "I don't need a nurse teaching me cardiology or ordering diagnostic tests. Please attend to your assigned nursing duties and leave the medical decision-making to physicians who are trained and qualified to make those determinations." The exchange was witnessed by several residents and other nurses, creating an uncomfortable silence in the cardiac unit that seemed to stretch on forever. Maria retreated to continue her nursing duties, but she didn't stop monitoring Mrs. Chen closely, documenting every change in the patient's condition with meticulous detail. 4 hours later, Mrs. Chen went into acute cardiac distress exactly as Maria had predicted. Emergency echocardiogram revealed significant pericardial effusion that required immediate surgical intervention to prevent cardiac tamponade, a potentially fatal condition where fluid around the heart prevents it from beating effectively. The delay in diagnosis had made the procedure more complex and dangerous than it needed to be. What could have been a simple drainage procedure performed at bedside became an emergency surgery requiring a return to the operating room. Mrs. Chen survived, but the complication extended her hospital stay by 5 days and put her through unnecessary risk and discomfort. Maria's accurate early assessment had been completely vindicated by the subsequent events, but Dr. Harrison never acknowledged his error or Maria's expertise. In fact, he seemed to view the incident as an unfortunate coincidence rather than a failure of his own diagnostic process. Over the following months, a toxic pattern developed between Dr. Harrison and Maria that affected the entire cardiac unit. She would identify concerning signs in patients based on her extensive experience and pattern recognition skills, and he would dismiss her observations without serious consideration, often in ways that undermined her credibility with other staff members. "Maria Santos thinks she's a cardiologist," Harrison would tell residents when he thought Maria couldn't hear him. "It's important not to let nursing staff overstep their boundaries in medical decision-making. They mean well, but they lack the education and training to understand complex cardiac pathophysiology. We can't run a medical unit based on nursing hunches and subjective feelings. But Maria's track record spoke for itself, and the pattern of her being right and Harrison being wrong continued to repeat itself with disturbing regularity. She identified a developing arrhythmia in a 45-year-old post-surgical patient named Robert Martinez 3 hours before it showed up on continuous monitoring. Maria had noticed subtle changes in the patient's demeanor and energy level that suggested electrical instability in his heart rhythm. Harrison dismissed her concerns as nursing anxiety until the patient went into sustained ventricular tachycardia and required emergency cardioversion to restore normal rhythm. She recognized signs of digoxin toxicity in an elderly patient named Martha Williams when his blood levels were still within the supposedly normal therapeutic range. Maria had observed changes in the patient's mental status, vision complaints, and subtle heart rhythm irregularities that indicated the medication was reaching toxic levels despite normal blood work. Harrison ignored her recommendation to adjust the dosage, insisting that blood levels were the only reliable indicator of toxicity, until the patient developed dangerous bradycardia that required intensive intervention and nearly resulted in permanent cardiac damage. She spotted early signs of surgical site infection in a bypass patient's chest incision 2 days before bacterial cultures confirmed her suspicion. Maria had noticed subtle changes in the appearance of the incision, minor temperature elevation that fell within normal ranges, and behavioral changes in the patient that suggested developing sepsis. Harrison had attributed the patient's symptoms to normal post-operative recovery and delayed antibiotic treatment until the infection had spread significantly. She predicted heart failure decompensation in a patient whose ejection fraction numbers looked stable. Maria had recognized fluid retention patterns, changes in exercise tolerance, and subtle respiratory changes that indicated the patient's heart function was declining despite normal-appearing test results. Harrison dismissed her observations until the patient required emergency diuretic therapy and extended hospitalization. Each incident followed the same frustrating pattern. Maria would raise concerns based on her clinical experience and pattern recognition abilities. Harrison would dismiss them as unscientific nursing intuition. And then Maria would be proven correct when the patient deteriorated exactly as she'd predicted. The delays in appropriate treatment caused by Harrison's dismissiveness led to worse outcomes for patients, longer hospital stays, and unnecessary complications that could have been prevented. The nursing staff began documenting these incidents meticulously, partly out of frustration and partly out of concern for patient safety. But Harrison's surgical success rate and his standing with hospital administration protected him from serious criticism or accountability. What started as professional dismissal gradually became personal hostility as Harrison began to see Maria's accurate predictions as challenges to his authority rather than valuable clinical input. He began actively undermining Maria's credibility with other staff members and hospital administration, portraying her expertise as dangerous overreach that threatened proper medical hierarchy. Nurse Santos has difficulty accepting medical hierarchy and her appropriate role in patient care, Harrison wrote in a formal complaint he filed with nursing administration. Her repeated attempts to override physician judgment and order diagnostic tests create confusion among junior staff and could potentially compromise patient safety by encouraging nurses to practice beyond their scope of training. Harrison lobbied actively to have Maria removed from his service, claiming that her insubordination, and failure to respect physician authority created a disruptive work environment that interfered with proper patient care. He made specific scheduling requests that would limit Maria's access to his patients, and he instructed residents and medical students not to engage with her clinical observations or take them seriously. "I don't want Nurse Santos involved in my patient's care," Harrison told Dr. Jennifer Walsh, the cardiac surgery chief resident, during a private conversation. "She's overconfident in her abilities and interferes with proper medical decision-making processes. I need residents who understand that clinical decisions are made by physicians based on scientific evidence, not by nurses based on intuition and feelings." But Dr. Walsh had worked with Maria for 2 years and had witnessed firsthand her remarkable diagnostic abilities. "Dr. Harrison, Maria Santos, is one of our most experienced cardiac nurses. Her clinical instincts are usually spot on, and she's caught complications that our monitoring systems missed." "Dr. Walsh," Harrison replied coldly, his tone carrying clear warning, "you're a resident under my supervision. I expect you to follow my guidance regarding appropriate interactions with nursing staff and maintain proper medical hierarchy. Nurses provide nursing care. Doctors make medical decisions. That distinction is fundamental to proper hospital function." Maria found herself increasingly isolated from the cardiac cases where her expertise was most valuable and most needed. Other nurses began avoiding her, afraid that association with her would damage their own relationships with Harrison and affect their performance evaluations. The toxic dynamic was affecting the entire unit's morale and patient care quality. Ironically, while Harrison was working systematically to discredit Maria's diagnostic abilities and remove her from patient care, she was observing concerning signs in Harrison himself that he was either ignoring or hadn't recognized. Her trained eye, honed by decades of watching cardiac patients, was picking up subtle signs that Harrison's own cardiovascular system was under dangerous stress. During long surgical procedures, Maria noticed that Harrison would occasionally pause and discreetly press his hand to his chest, as if experiencing discomfort he didn't want others to notice. He developed a slight pallor during particularly stressful procedures, and she observed him taking what appeared to be antacid tablets with increasing frequency throughout his shifts. Most concerning to Maria were the subtle changes in Harrison's surgical performance during these episodes. His typically rock-steady hands would show minute tremors that lasted for several seconds, and his decision-making would become slightly less sharp during moments when he appeared to be experiencing physical discomfort. These were exactly the types of subtle changes that Maria had learned to recognize as early warning signs of cardiac distress. Maria's trained eye recognized the classic signs of developing cardiac issues, probably stress-related arrhythmia, or early coronary artery disease complicated by the high-stress environment of cardiac surgery. Harrison was a classic Type A personality working in an extremely stressful environment, maintaining poor dietary habits, getting inadequate sleep, and showing textbook symptoms of cardiovascular strain that were likely to worsen without intervention. She debated whether to approach him directly about her observations, but their history of professional conflict made that approach impossible. Harrison had made it clear that he didn't value her clinical input on any topic, and she knew that expressing concern about his personal health would be viewed as another example of her overstepping boundaries. Instead, she mentioned her concerns to Dr. Williams during a private conversation, hoping that someone Harrison respected might be able to address the situation. "Patricia," Maria said carefully during a quiet moment in the break room, "I'm worried about Dr. Harrison's health. I've noticed some signs that suggest He might be developing cardiac issues that need medical attention. Dr. Williams paused in her chart review, understanding the gravity of what Maria was suggesting. That's a serious concern, Maria. What specific signs have you observed? Maria detailed her observations systematically. The chest discomfort episodes, the pallor during high-stress procedures, the changes in manual dexterity during apparent discomfort episodes, and the increasing use of what appeared to be cardiac medications or antacids. She described the pattern she'd observed and why it concerned her from a cardiac nursing perspective. You should talk to him directly about this, Dr. Williams suggested, though her tone suggested she understood the complexity of the situation. He won't listen to me, Maria replied honestly. He's made it very clear that he doesn't value my clinical observations, and approaching him about his personal health would probably be seen as another example of inappropriate behavior. Dr. Williams sighed, understanding the difficult position Maria was in. I'll keep an eye on him during procedures and see if I notice anything concerning. But Maria, if you see something acute developing, don't hesitate to speak up, regardless of your past conflicts. His life could depend on it. The crisis came on a Wednesday morning in November, during what should have been a routine cardiac catheterization procedure. Harrison was performing the diagnostic procedure on James Mitchell, a 52-year-old construction worker with suspected coronary artery disease who had been experiencing chest pain during physical exertion. Maria was assigned to the cardiac catheterization lab that day, despite Harrison's explicit preference for other nurses to work his cases. A scheduling conflict involving two other nurses calling in sick had left her as the only available experienced cardiac nurse for the procedure, and hospital policy required experienced nursing support for all catheterization procedures. The procedure began normally, with Harrison displaying his typical confident demeanor and precise technical skills. He guided the catheter through James Mitchell's cardiovascular system with the expertise that had made his reputation, providing calm commentary for the residents observing the procedure. But about 20 minutes into what should have been a 40-minute procedure, Maria noticed changes in Harrison's behavior and physical presentation that immediately triggered her professional alarm systems. His breathing became slightly labored, though he was clearly trying to hide it from the other staff members in the room. She observed him discreetly wiping perspiration from his forehead more frequently than the sterile environment and moderate room temperature would require. Most telling to her experienced eye, his typically rock-steady hands showed barely perceptible tremors as he manipulated the catheter through the patient's arterial system. "Dr. Harrison," Maria said quietly, her voice carrying the concern of someone who had seen these exact signs hundreds of times before. "Are you feeling all right?" "I'm fine, Nurse Santos," Harrison replied tersely, not looking away from the fluoroscopy screen showing the catheter's progress. "Please focus on monitoring the patient's vital signs and cardiac rhythm." But Maria could see that Harrison was developing classic signs of acute cardiac distress. His face had acquired a grayish pallor that she recognized from years of treating heart attack patients, and his breathing pattern suggested someone whose cardiovascular system was under severe strain. The perspiration on his forehead wasn't from room temperature or procedural stress. It was diaphoresis, the cold sweat that often preceded cardiac events. "Sir," Maria said more urgently, her professional instincts overriding their personal conflicts, "I think you should consider having Dr. Walsh complete this procedure." Harrison's response was sharp and immediate, his voice carrying frustration and embarrassment that the nursing staff was questioning his fitness. "Nurse Santos, I am perfectly capable of completing this procedure. Your job is to monitor the patient's condition, not the physician's condition." Dr. Harrison, Maria pressed, her voice carrying the authority of someone who had seen these exact symptoms lead to disaster many times before. You're showing signs of acute cardiac distress. You need medical attention immediately, and this procedure needs to be completed by another physician. Harrison paused in his work, turning to face Maria with an expression of barely controlled anger and professional humiliation. Nurse Santos, you are completely out of line. I am not your patient, and I don't need medical advice from a nurse who has repeatedly demonstrated poor judgment and inappropriate behavior. Sir, please listen to me, Maria said urgently, her voice carrying the desperation of someone who could see disaster approaching but was powerless to prevent it. I've been watching cardiac patients for 23 years. You're having cardiovascular symptoms that require immediate medical intervention. Harrison's voice rose enough for the entire catheterization team to hear, his professional composure cracking under the stress and embarrassment. Nurse Santos, you are hereby removed from this procedure immediately. Your behavior is unprofessional, disruptive, and completely inappropriate. Leave the lab right now. But as Harrison turned back to continue the procedure on James Mitchell, Maria saw something that made her blood run cold. His hand was trembling more noticeably now. Perspiration was beading more heavily on his forehead, despite the cool temperature of the lab, and his breathing had become visibly labored. Dr. Harrison, Maria said one final time, her voice cutting through the tension in the room with the authority of someone making a life or death warning. You're having a heart attack. You need to stop this procedure immediately and get medical help before you collapse. Harrison whirled around, his face flushed with anger, embarrassment, and what Maria now recognized as the confusion that often accompanied cardiac events. "Get out!" he shouted, his voice echoing off the walls of the catheterization lab. "Get out of my lab right now!" As Maria reluctantly moved toward the door, Harrison turned back to the procedure table and muttered loud enough for everyone in the room to hear. 23 years of experience, and she still thinks she knows more than a cardiologist. Some nurses never learn their place in the medical hierarchy. The comment was his last conscious statement before disaster struck. Maria had barely reached the hallway outside the catheterization lab when she heard the distinctive sound of equipment alarms and the immediate code blue announcement over the hospital intercom system. Her heart sinking with the terrible knowledge of what she would find, she rushed back into the room where she had just been banished. Dr. Harrison was unconscious on the floor beside the procedure table, his body convulsing in what was clearly cardiac arrest. The patient, James Mitchell, was stable on the table with the catheter still in place, but the procedure had been abandoned midway through when Harrison collapsed. The Code Blue team rushed into the room within 90 seconds, but they were focused on basic resuscitation protocols and didn't immediately recognize the specific type of cardiac emergency they were dealing with. Maria took one look at Harrison's presentation and the cardiac monitor displaying his heart rhythm, and immediately recognized what the others were missing. "He's in ventricular tachycardia," Maria announced, reading the cardiac monitor with the expertise of 2 decades spent interpreting dangerous heart rhythms. "He needs immediate cardioversion, not standard CPR protocols." Dr. Jennifer Walsh, who was leading the Code Blue response, looked at the monitor and confirmed Maria's rapid assessment. "She's right. Get the defibrillator ready immediately." But as the team prepared the defibrillator for cardioversion, Harrison's heart rhythm deteriorated from ventricular tachycardia to ventricular fibrillation, a chaotic, potentially fatal arrhythmia that required immediate electrical shock to correct before permanent brain damage occurred. "We need to shock him now," Dr. Walsh said, but her hands were shaking with the pressure of the moment and the responsibility of making life or death decisions for her supervising physician. Maria stepped forward without hesitation. "Dr. Walsh, I've handled hundreds of cardioversions and defibrillations during my career. Let me do this." The room fell silent, except for the alarm sounds from Harrison's cardiac monitor. Maria Santos, the nurse who had just been kicked out of the procedure for overstepping her boundaries and not knowing her place, was now being asked to save the life of the doctor who had spent 3 years humiliating her and undermining her professional credibility. Maria took the defibrillator paddles with hands that were completely steady, her 23 years of emergency cardiac experience taking over, despite the emotional weight of the moment and the historical context of her relationship with Harrison. Around her, the medical team watched in tense silence as she positioned the paddles with the precision of someone who had performed this life-saving procedure countless times. "Everyone clear," Maria announced, following the same safety protocol she'd used hundreds of times before, ensuring that no one was touching the patient or the bed before delivering the electrical shock. She looked down at Dr. Harrison's unconscious form, and for just a moment, the weight of their history together flashed through her mind. Every dismissive comment, every professional humiliation, every time he'd made her feel like her expertise didn't matter, every patient who had suffered because he wouldn't listen to her warnings. For just a moment, she hesitated. Then, Maria's professional training, ethical commitment, and fundamental humanity took over completely. Regardless of how Harrison had treated her, regardless of the years of professional abuse and dismissal, he was a human being who needed her help, and she was a healthcare professional who had sworn to preserve life above all other considerations. "Shocking now," Maria announced clearly, and she delivered the electrical charge that would either save Harrison's life or confirm his death. The first shock caused Harrison's body to arch dramatically off the floor, every muscle contracting simultaneously, but when the electrical current ended, his heart rhythm remained in the chaotic pattern of ventricular fibrillation. "Still in V-fib," called out the technician, monitoring the cardiac display. "Charging for second shock," Maria said, her voice remaining calm and professional despite the enormous pressure of the moment and the knowledge that Harrison's brain was being deprived of oxygen with every passing second. The second shock finally converted Harrison's heart rhythm back to normal sinus rhythm. His heart was beating regularly again, but he remained unconscious and his condition was still critical. The electrical shock had restored his heart's normal rhythm, but the underlying problem that had caused the cardiac arrest still needed to be identified and treated. "Get him to cardiac ICU immediately," Dr. Walsh ordered. "Maria, I want you to accompany him and continue monitoring his cardiac status during transport." As they prepared to transport Harrison to the ICU, Maria found herself in the surreal position of providing emergency care to the man who had spent 3 years trying to undermine her career and remove her from patient care responsibilities. In the cardiac ICU, Maria's expertise became absolutely crucial to Harrison's survival and recovery. As he regained consciousness over the following hours, she was the one continuously monitoring his heart rhythms, adjusting his cardiac medications based on his response, and recognizing subtle changes in his condition that required immediate intervention. The diagnostic workup revealed exactly what Maria had suspected based on her weeks of observation. Dr. Harrison had suffered a myocardial infarction, a heart attack, caused by a previously undiagnosed significant blockage in his left anterior descending coronary artery. The stress of performing surgery, combined with his underlying cardiac condition and type A personality, had triggered the acute episode that nearly killed him. The blockage is about 85% occlusion, Dr. Walsh explained to Harrison when he was stable enough to understand the full implications. You've probably had developing symptoms for weeks or even months. This was building toward a major cardiac event. Harrison was quiet for a long moment, processing the reality that he had nearly died from the exact type of condition he specialized in treating in other patients. If Nurse Santos hadn't recognized the signs of ventricular tachycardia and insisted on immediate cardioversion, Dr. Walsh continued, you would have died on that catheterization lab floor. Her quick recognition and intervention saved your life. Harrison turned to look at Maria, who was quietly checking his cardiac monitor readings and adjusting his medication drip rates. How long had you been observing symptoms in me? He asked quietly. About 6 weeks, Maria replied honestly, maintaining her professional demeanor. I tried to mention my concerns to Dr. Williams, but I knew you wouldn't listen if I approached you directly about it. Harrison closed his eyes, understanding the terrible irony of the situation. The nurse whose clinical observations he had dismissed for 3 years had been trying to save his life for weeks before his cardiac arrest. You tried to warn me today, didn't you? In the catheterization lab. Yes, sir. I could see the signs of acute cardiac distress developing during the procedure. And I threw you out of the lab for trying to help me. Yes, sir. Harrison was quiet for several minutes, contemplating the fact that his arrogance and dismissiveness had nearly cost him his life, and that his survival depended entirely on the expertise of the nurse he'd spent years undermining and humiliating. Harrison's recovery took several weeks, during which Maria was assigned as his primary cardiac nurse, an assignment that was initially awkward but forced both of them to confront their professional relationship in a completely new context. Maria, Harrison said one evening, as she checked his medications and adjusted his cardiac monitoring equipment, I owe you an apology. Actually, I owe you several apologies. And probably my life. Maria looked up from his chart, surprised by the use of her first name and the genuine humility in his voice, a tone she had never heard from him before. You've been right about every single clinical observation you've made over the past 3 years, Harrison continued, his voice carrying the weight of someone who was finally understanding the magnitude of his mistakes. Mrs. Chen, the medication toxicity case, the post-operative infections, the heart failure decompensation. You saw things I missed because I was too arrogant to listen to expertise that didn't come with an MD degree. Dr. Harrison. Let me finish, Harrison interrupted gently, his tone completely different from the authoritative dismissals she was used to. You tried to save my life twice, once by warning me about my developing symptoms, and once by actually saving my life when I collapsed. And I treated you like you were incompetent and dangerous. Maria set down his chart and faced him directly. Dr. Harrison, you're not the first physician who's had difficulty accepting input from nursing staff. The hierarchy in medicine can make communication challenging between different professional levels. No, Harrison said firmly, his voice carrying conviction. This wasn't about medical hierarchy or communication challenges. This was about arrogance, disrespect, and my failure to recognize expertise when it didn't come in the form I expected. You have knowledge and skills that I ignored, and patients suffered because of my attitude. Over the following days, Harrison asked Maria to explain her thought process behind her various clinical observations over the years. What he learned humbled him completely and changed his understanding of nursing expertise forever. Maria's expertise wasn't just based on formal education. It was based on decades of hands-on experience with cardiac patients that had given her pattern recognition skills that textbooks couldn't teach. She had developed an ability to recognize subtle changes in patient condition hours or even days before they became obvious to others, even those with more formal medical training. "You're like a cardiac specialist," Harrison realized during one of their conversations. "You've just specialized through experience and observation rather than formal fellowship training. 23 years of cardiac nursing teaches you things that medical school can't," Maria replied. "You learn to see patterns, to recognize changes that aren't yet measurable, to trust your instincts when they're based on solid experience." Harrison's near-death experience and his understanding of Maria's true expertise led to a complete transformation in his approach to working with nursing staff. When he returned to active practice 6 weeks later, he was fundamentally a different physician with a completely new appreciation for collaborative patient care. "I want to implement a new protocol in our department," Harrison announced during his first department meeting after his return to work. "I want all nursing observations and concerns to be formally documented, reviewed, and addressed by physicians. We've been ignoring a valuable source of clinical expertise that could prevent complications and save lives." He publicly acknowledged Maria's role in saving his life, crediting both her early warnings about his developing condition and her emergency response during his cardiac arrest. "Nurse Santos recognized signs of my developing cardiac condition that I missed in myself," Harrison told the assembled medical staff during a department meeting. "Her expertise has been invaluable to patient care in this department for years, and I deeply regret that it took a personal crisis for me to recognize and value that expertise." Harrison began consulting with Maria on complex cases, asking for her assessment of patient conditions and incorporating her observations into his treatment planning. The change was dramatic and immediate, affecting not just his own patient care, but the entire culture of the cardiac department. "Dr. Harrison's become a completely different doctor," Dr. Walsh observed to other staff members. "He actually listens to nursing input now, incorporates it into his decision-making, and his patient outcomes have improved significantly as a result." Maria found herself in an unprecedented position. A nurse whose clinical expertise was being actively sought and valued by the department's most skilled cardiologist, transforming her from an outsider to a central figure in patient care planning. The professional relationship that developed between Harrison and Maria became a model for physician-nurse collaboration throughout St. Catherine's Medical Center and eventually influenced practices at hospitals throughout the region. They began presenting cases together at medical conferences, demonstrating how nursing expertise could enhance physician decision-making and improve patient outcomes. "Maria Santos has taught me that expertise comes in many forms," Harrison would tell audiences of healthcare professionals. "Her pattern recognition skills, developed through decades of direct patient care, often identify problems that traditional diagnostic methods miss entirely." Their collaboration led to dramatically improved outcomes for cardiac patients throughout the department. Maria's early warning system, now formally integrated into patient care protocols, prevented numerous complications and emergency situations. "I've learned to recognize Maria's clinical instincts," Harrison would tell residents and medical students. "When she says something's wrong with a patient, we investigate immediately and thoroughly, regardless of what the monitors or laboratory results show." The comment contained a profound truth. Maria's intuitive understanding of cardiac conditions had become an essential tool in the department's diagnostic capabilities. 3 years after Harrison's cardiac arrest, the cardiac department at St. Catherine's Medical Center had become nationally known for its collaborative approach to patient care. The Santos Protocol, named after Maria's systematic approach to recognizing early warning signs, was being implemented in hospitals throughout New England and beyond. We've seen a 40% reduction in unexpected cardiac events since implementing the Santos Protocol, Dr. Williams reported to hospital administration. Nursing observations are now formally integrated into our diagnostic process, and patient outcomes have improved dramatically. Harrison had become a passionate advocate for nursing expertise throughout the medical community, speaking at conferences about the importance of listening to experienced nurses and integrating their observations into medical decision-making. "I nearly died because of my arrogance and failure to listen," Harrison would tell audiences of physicians. "But I lived because a nurse I dismissed and humiliated possessed exactly the expertise I needed to survive. That experience taught me that medical knowledge comes in many forms." Maria was promoted to cardiac clinical specialist, a newly created position that recognized her unique expertise and gave her formal authority to implement early warning protocols throughout the hospital system. She began training other nurses in pattern recognition and early warning systems, spreading her knowledge and approach throughout the healthcare community. 5 years after that dramatic day in the catheterization lab, Harrison and Maria had developed one of the most effective physician-nurse partnerships in the hospital. Their collaboration had saved countless lives and had fundamentally changed the culture of the entire cardiac department. "You know," Harrison said to Maria one day, as they reviewed complex cases together, "I spent 3 years trying to prove that you didn't know what you were talking about. I was completely wrong about everything." "You were protecting what you saw as your area of expertise," Maria replied diplomatically, her natural graciousness allowing Harrison to maintain some dignity despite his past behavior. "No," Harrison said firmly. "I was protecting my ego, and there's a fundamental difference. True medical expertise requires humility, the recognition that knowledge and insight can come from unexpected sources." Harrison had learned that dismissing valuable input because of professional hierarchy wasn't just arrogant. It was dangerous to patients and potentially fatal to physicians who thought they knew everything. The heart doesn't care about medical degrees or professional hierarchy, Harrison often told medical students and residents. It responds to knowledge, skill, and experience, regardless of where that expertise comes from or what credentials the person possesses. On the anniversary of Harrison's cardiac arrest, the department held a celebration, not of his near-death experience, but of the transformation it had sparked in their approach to patient care and professional collaboration. "I owe my life to Maria Santos," Harrison said during the gathering. "But more than that, our entire department owes its success to her willingness to share her expertise, despite years of being dismissed and undervalued." Maria was characteristically modest in her response. "We're all here to serve patients and save lives," she said. "When we work together and respect each other's knowledge and experience, everyone benefits, especially the patients who depend on us." But privately, Maria felt a deep satisfaction in knowing that her expertise was finally being recognized, valued, and utilized to its full potential. The nurse who had been told to know her place had found her rightful place at the center of cardiac care decision-making. Harrison's transformation had been complete and permanent. The arrogant cardiologist who had once dismissed nursing input as irrelevant had become the physician who insisted that Maria's observations be the first consideration in any complex case. "If Maria Santos is concerned about a patient," Harrison would tell residents and medical students, "that patient becomes our top priority regardless of what the monitors, lab results, or imaging studies show. Her expertise has taught me that the most important data often can't be measured by machines. Perhaps the most profound change was in how both healthcare professionals understood the nature of medical expertise itself. I used to think expertise was about knowing all the answers, Harrison reflected during a conference presentation. Now I understand that true expertise is about asking the right questions and being willing to learn from anyone who might have insights. Maria's perspective had evolved as well. I spent years thinking that if I just did good work, eventually people would notice. I learned that sometimes you have to advocate for your expertise to be heard. Not for personal recognition, but because patients' lives depend on it. Their story became more than just a tale of professional redemption. It became a fundamental challenge to how healthcare systems think about knowledge, authority, and collaboration. 10 years after that life-changing day in the catheterization lab, the impact of their story continued to grow. Medical textbooks included their case study. Hospital administrators worldwide studied their collaborative model. Thousands of healthcare professionals had been trained in their approach to interdisciplinary care. But for Harrison and Maria, the most important measure of success remained simple: the patients whose lives had been saved by better communication and collaboration. Every time a nurse's observation prevents a complication, every time a physician listens to nursing input, every time we work together instead of in hierarchy, that's when we know this work matters, Maria said during their final joint presentation before retirement. Harrison's closing remarks captured the essence of what they had learned. I laughed at a nurse's warning, and minutes later, she controlled my heart. That taught me the most important lesson of my medical career. The person whose voice you dismiss might be exactly the person whose expertise you need to survive. Their story proved that sometimes the most important medical breakthrough isn't a new drug or surgical technique. It's the simple recognition that expertise comes in many forms, and the courage to listen when someone with experience tries to warn you about danger you cannot yet see. In the end, the nurse they called overconfident had been exactly as confident as her expertise warranted. The cardiologist who had demanded respect for his authority had learned to respect the authority of experience, observation, and professional courage. Sometimes the person whose warnings you ignore is exactly the person whose expertise you need to survive. And sometimes the heart you need to save most is the one belonging to the person who couldn't hear your warnings until it was almost too late. Dr. Harrison had laughed at the nurse's warning, but minutes later, she controlled not just his heart, but his life, his career, and his understanding of what true medical expertise really means. If you've been inspired by this incredible story of professional respect and life-saving expertise, subscribe to Profession Stories for more amazing tales from the healthcare world. Have you ever had your professional expertise dismissed, only to be proven right when it mattered most? Share your experiences in the comments below.